Hi, welcome everyone, and good morning from San Francisco for our webinar on financial sustainability, a conversation on frameworks, strategies, and lessons learned. I'm so pleased so many of you can join us, and even more pleased that we've got wonderful speakers lined up for today who have very different perspectives on this topic. I'm going to first start off by addressing any audio issues. Let's handle that right now. If you cannot hear me particularly well, if I'm coming in and out, please do let me know. Just chat into the chat box. So I'll give you guys maybe 20 seconds, half a minute to please type in your comments to me and let me know if you can hear me well. Okay, it looks like everything is going well. I'm getting comments that you all have audio. Excellent. So we'll just move into the webinar right now. I'm speaking to you from the University of California at San Francisco's Global Health Group. My name is Rekha Vishwanathan, and the technical manager for this online event is Avery Seefeld. Again, we're pleased to have you join us and thrilled to be convening this event. The Global Health Group at UCSF serves as the secretariat for a global community of practice for social franchises around the world. And the members of this community include social franchise programs in over 30 countries. It also includes donors, bilateral agencies, NGOs, and researchers and academics with an interest in franchising and public health. It's a diverse group and a very motivated group. The theme for this event is financial sustainability. The intent of this webinar is to provide practical, case-based insights based on work done by social franchises in this area. Now, so financial sustainability can be interpreted several ways. There's no one standard or approach. How franchisers define this for themselves and put it into practice can depend on their mission, their view of how they contribute to public health, and opportunities they see in the healthcare marketplace. Franchises may also need to negotiate a balance between potentially costly and important aims, like reaching populations in remote areas, and their goals for financial sustainability. So this is a uniquely interesting topic that's tackled quite differently by various franchisers. So we're going to hear multiple perspectives today. First, we'll hear from the former head of the Smiling Sun social franchise program in Bangladesh. Next, we'll hear from the executive director of the Linked Foundation, which is an impact investment organization that invested in the Tiendas de la Salud pharmaceutical franchise in Guatemala. We'll follow this with a presentation from Nathan Blanchette of the Results for Development Institute, who will walk us through an ongoing assessment of the most promising pathways to financial sustainability for a few social franchises in Tanzania, Nigeria, and Uganda. Time permitting, we'll hear about all three cases. Then I will open up the platform for an open discussion. I would very much welcome you to please write in your comments and questions at any time, including now. All you have to do is to type in your comments or questions in that chat box on the lower left-hand side of your interface. I'll simply save your questions, queue them up, and when it comes time for the open discussion, we'll start asking our presenters systematically. And then we'll close by linking you to useful resources, and we'll also make this a video recording of this event available to you afterwards. So I'd like to take this moment to introduce our speaker number one. Mr. Juan Carlos Negret is probably known to most of you as stalwart in the community of practice. He has more than 25 years of international experience in health program design, implementation, and management. He's successfully directed health service delivery programs, including the Smiling Sun social franchise in Bangladesh, and commercial healthcare activities. Juan Carlos, over to you.
Oh, well, thank you. Thank you, Rekha. Well, good morning to all. Thank you for that kind of introduction. I will start quickly walking you through the experience I had with the Bangladesh Smiling Sun franchise program and how we saw sustainability in this country project. One thing is important to mention here is the vast coverage, and which is essential for our conversation, that the Smiling Sun network achieved in Bangladesh with more than 320 clinics and present in almost every single district in the country. The So the way we define sustainability is more like an organic response, and to consistently deliver value to society, and that value generates an exchange that allows the organization to acquire resources to address its structural needs as well as project it into the future. So going back to the project in Bangladesh, we had three major objectives. So if you want to think of this as a triple bottom line thing, the idea was to expand access to health services. The other, it was to increase access to the poor, for services to the poor. And the other is at the same time to increase financial sustainability. So what we thought is that perhaps we would have to come up with investment in key areas, which we define those as generators of what would be the kernel for sustainability, or the sustainability determinants. Those would generate resources that we would reinvest to accomplish our social mission. So this is the diagram and that we use as a reference, or if you want the pathways model that we use in this case. So one is that, first of all, when working with these clinics, we had to turn them into a franchise clinic, and some of those existed, others were new. But at the end of the day, they should reflect the same character throughout the nation. So we call this phase the conversion, or we call this phase the conversion phase. And what were the elements that we had there? Well, we had some two key factors that we had to consider. One was that we would have to develop capacity in the staff. By that I refer clinical and medical capacity, and at the same time managerial capacity. That was an important element. The other was the physical enhancement of the facility. So from a rundown or a not necessarily adequate facility for service delivery, to turn it into a Smiling Sun clinic with a very distinct way of looking. So one important aspect. We had three pillars in this effort. One was to create an ethos around the organization about centering their energy into the client, and letting people understand that at the end of the day, who paid for their salaries in their clinics were not the donors, but the woman that entered to the clinic, most likely barefooted into the clinic to ask for services, and focusing on quality of care in this case and measuring it. The other was to develop modern management systems, and also train people how to manage what would be a modern clinical practice, if you want. And the other was to develop and to further enhance the brand equity of the organization, which, by the way, people already knew Smiling Sun as a loose operation of clinics. So it should result in higher value perception for the user, I should draw arrows here from one to the next, increase client loyalty, increase client traffic, and for that we should generate more revenue. So those were the determinants for sustainability. So what elements were essential for us? Two categories. One, endogenous factors, and the other were exogenous factors. So I think Smiling Sun was ripe for sustainability, if you want, and to achieve financial sustainability, because first of all, USAID had already invested for years in a loose network of service delivery that had some level of recognition and already had some level of assets and that could deliver through which they could deliver services. The other was that this structure was relatively highly diversified for a primary care facility, including child care, maternal care, and at the same time other diagnostic services and general health. That was good. And the other was that at this point when we started doing this, there was room for growth, and the clinics were not overcrowded, so there was room to expand services with the installed capacity we had. An interesting and important factor that I frankly initially did not fully grasp was the organizational culture. I mean, there was already a sense of belonging to this both association with USAID and the way people were delivering services, mainly because people saw themselves as charity providers. That was an important consideration. The other endogenous factor, and the other set of factors, what we call endogenous factors, was that Bangladesh has half of the U.S. population in Iowa. So more density than that is very difficult to achieve. So people is basically close to each other. And it was every clinic you set up, it was in a highly populated area by comparison to any other country. And the other is that people were accustomed already to pay for services. Out-of-pocket payments in Bangladesh are pretty high, and coverage of health insurance is pretty low. So that is another element. People were ready to pay for services we were offering. The other is that is important here was the government was supporting our efforts. We had a good relationship with both DGs, DG General, and DG Health, and also the DG from local governments, which, by the way, they controlled half of they were local units were responsible for providing healthcare to half of the population in Bangladesh. One important element here is that there's certain cultural traits that we have to address, that have to do with corruption and transparency. And the other is that it was important for us to understand that there were already other private practitioners in this space, and they were already claiming some niche. So just to go quickly to the initial results in services to the poor, just for you to see, our baseline was 26% towards the year 3 of the project. Out of 4 years was 31% based on the metrics we had. We were following some of the indicators that NDHS used to define poverty at that time. And at the same time, we increased the cost recovery, or this was one of our measures, revenue versus operational costs, from 25% to 46%. We're a bit short of the 50% mark at that time. Now, still, when we were moving forward, some challenges still remain. And when we left the organization, when we left the project, I understand USAID reverted to did not continue with the concept of financial sustainability the way it was defined previously, nor social franchising as we understood it to facilitate this, to achieve these financial objectives, and both social and service objectives as well. But on top of that, the idea was that we always have to track the environment. I mean, there are always changing needs in the environment, and it's important that to adjust a bit our equation. Cultural does matter. Cultural is a strategy for lunch, and it was important for us to understand that donor dependence and the ethos of donor dependence was something we had to deal with. And the other is that we were dealing with 30 different franchisors in the country, and every one of them have their own agenda, and both service and political. Some of them were highly influential, and so to put this into context was important also for sustainability purposes. And the other is that it was important, and this is an important lesson for us, to set financial and operational objectives for the organization that everybody understood was central for our strategy. And to be frank, initially, when seeing things only as sustainability as an outcome from doing certain things was not enough. I mean, we see this now. I see sustainability now more or less as a process and an outcome simultaneously. And something that we were told it would never happen is that people in Bangladesh would not necessarily appreciate higher levels of quality, so we should not invest that much money in revamping clinics. Well, lessons we received from the field is that people do care about quality, people do care about the way things look, and therefore their affiliation with the service provider is essential, and this element is important to achieve it. So, well, that's what I have.
Thank you, Juan Carlos. Let me take a moment to ask you a few questions then that'll be useful for the audience. My first question is, give us context here. How does financial sustainability fit in overall? What does success look like to you, and what indicators inform that picture?
Well, I think the success is defined by meeting social objectives for the project as well as operational and financial objectives. And it's important to have a time frame for those. I mean, so they have to be consistently achieved. And you can develop metrics for every one of them. And in financial, for instance, in our case, we said revenues, and revenues were, and perhaps there's a question from Joyce here. Revenues were, of course, and this basic equation of price times and services. So the idea was for us to adjust prices and adjust and also promote services. That was central to our activity. And also to keep not to keep a lead, but to keep an eye on costs. I mean, mainly operational costs and salaries. Remember, salaries are 70% of these operations, or it was 70% for us. So those were on the financial side. Operational well service per unit of production was really important, and also to evaluate the level of knowledge of providers. As an example, in social, we're service to poor, and as an absolute, and the number of services provided poor as a percentage as well, and level of cross-subsidization. Some clinics were achieving higher levels of financial sustainability. They were more in better capacity to help others. Some services in our product or service equation, we consider how do they contribute to the overall sustainability of the system. Just to give you an example.
Thank you. Next question for you. How did your program define sustainability? Actually, I think you've already given us that definition. Shall we move forward to the third question?
Yeah, why not?
Tell me a little bit about how the vision for financial sustainability transformed over time and why.
Well, so from people from a number of organizations that we put together that were more accustomed to live and to derive their sustain as a charity organization, financial sustainability was not in the radar screen. It was totally irrelevant. And so the vision changed from being absolutely relevant to a key organizational objective. And that was perhaps the major achievement of the project, if you ask me.
Great, thank you. Juan Carlos, how has your financial sustainability strategy affected your core mission? Have there been trade-offs in terms of who is served, how they are served, and what services are offered?
Well, by the way we define sustainability, this is and your question, Reka, is very much related to the question number 2. So we thought it would be important to create the foundation for sustainability and expecting sustainability to happen. So the idea was to help clinics to differentiate. We understood how important was in reality and differentiation for potential clients. And we wanted to build on previous investment. We wanted to, so there was not a big change on those elements. We built capacity in staff, and we did a lot of our strategic thinking was in terms of developing a foundation for cross-subsidization. So we understood some services would be kind of loss leaders, if you want. So of course there's always kind of a tension when you are moving prices, and by definition you're limiting access. But at the same time, this is not what happened. We conducted an initial research that allowed us to look into maximization of volumes for pricing, and at the same time we promoted services. Initially, if you saw in one of the graphs, we went from having a higher level. We kind of decreased a bit on sustainability while we were moving in cost recovery. Services to the poor remained static and even fell a bit before they jump up. So so this graph here. So it was there's always a tension, but the idea is that thinking of sustainability as a result from the process that you're applying and keeping an eye on the process and setting objectives for that process is essential for you to manage both your objectives in this sense, but also to keep the balance in between the social mission and the financial results.
Okay, thank you, Juan Carlos. I've got one last question for you. Tell me about the top 3 lessons that you learned in terms of making plans for financial sustainability.
Well, one is culture does matter. That is a lesson that I learned both in the nice and the hard way. Please keep an eye on and be be wise enough to identify what are the cultural undercurrents that you have to deal with. Remember, this, as local as these businesses are, when international organizations are working with this space, they will be always dealing with this aspect. The other is it is very important, even though understanding sustainability as an outcome, it's very important to set objectives and that everybody understands, and objectives for everybody. And the other is that both clients and providers like to see themselves as providers of good quality and like to see themselves as recipients of good quality. So that is perhaps it.
Juan Carlos, thank you so much. We've got one clarification request, which I'm going to ask you right now, from an audience member. She asks, can you please clarify, are you talking about the financial sustainability at the franchisee or franchisor level?
We're talking about the network entirely, so it's both franchisee and franchisor.
All right, let's move to our next speaker. And remember, everyone in the audience, you will have a chance to get your questions answered during the open discussion format. So please do continue writing in your questions. I see several of you already have. I'm so happy that Ms. Nancy Swanson can join us today. She's the Executive Director of the Linked Foundation. This is a private foundation that invests in market-based solutions that improve the health and economic self-reliance of women and their families in Latin America. One of Linked's 2005 founding team members, her responsibilities include strategic direction and management of the portfolio. In 2009, the foundation invested in and supported the transformation of the TISA, the Tiendas de la Salud pharmaceutical franchise in Guatemala. In 2014, the model was adapted and is currently being piloted in Puebla, Mexico. Thank you, Nancy. Please take it away.
Thank you. Good morning. It's such a pleasure to be here. I really appreciate the opportunity through UCSF's Global Health team. They've actually helped us in the past on the Tiendas de la Salud model. So I wanted to spend just a few minutes to just share, to provide a little bit more context for our foundation, because it really describes the way we think about sustainability. As introduced, our mission is to promote and invest in market-based solutions that are improving the health and economic self-reliance of women and their families in Latin America. We've been very interested in, we're a sunsetting foundation, so we're at the top of year 11 in a 20-year life cycle for the foundation, and we've been very interested in creating business models that can outlive both the foundation and our funds, and so the emphasis has been finding the ways that we can do that with different types of models. And the franchising model has been one that we have been working on in Guatemala since 2008, which I'll share in more detail in a few moments. And then we also work in other areas within our portfolio, looking at different types of strategies using microfinance as a distribution platform for health, and also looking at low-cost company-operated health clinic models. And particularly for the rural pharmacy model, which I'll share more with you, have been working with corporate partners in both Guatemala and Mexico. We've been working with 2 pharmaceutical companies as the entity to make that happen. Oops, I've lost my arrow. There it is. Got it. And in terms of sustainability, we think about the kinds of business models that, and the way that we can use our capital, thinking about kind of early stage grant capital to de-risk and pilot models that are new, innovative, and that can, they have their own path to sustainability. And in both Guatemala and Mexico, I'll talk about the way we thought about it, both for the operating entity and the actual entrepreneurs that are running the stores. And we collaborate, we use our funding, we work with other partners. We believe in really working with other co-investors that are aligned around the mission that we want to achieve, and also bringing all that we can in working with the partners on the ground around the solution that we're seeking. And just to frame, I know most are familiar, but we always start with, what is the problem that we want to solve with this franchise model? and really looking at extremely limited access to essential medicines in rural indigenous communities all over the world. And where they do have access, the excessive costs in the case of this particular model, the travel cost to reach a public health center or to go into town is just, more than most people can even imagine. And when they arrive there, there's usually not products that they need. And so this model, both Tiendas de la Salud and what we call BOSI in Mexico, is designed to create access to affordable essential medicines, health products, and basic health education sustainably. And this is just a snapshot. I'd like to always remind myself of the kinds of communities that we're talking about. This is in Guatemala, where nearly half the children that are age 5 are malnourished. It's one of the highest in the world, 53%, and it's growing, unfortunately, of people live in poverty, and inequality remains extremely high. And so these are the kinds of communities that are targeted with this model. And for both, in both countries, I wanted to provide just an overview of how the rural pharmacy model works. It's a network of owner-operated health stores that are providing affordable, high-quality generic medicines and basic health products to people in rural communities in both Guatemala and Mexico. Essentially, entrepreneurs are recruited, I'll talk about some of the challenges and how key that is. They are provided with microloans, supplies, training, discounted medicines in both countries. It has ranged between a 20 and 30% discount to the entrepreneurs, and then they're sold at a market rate in their communities. They're provided ongoing coaching and training, both in health and business, and that's an essential aspect of the model. And they open up small pharmacies or botiquinas, health stores that are providing low-cost medicines and health products in their communities, and in some cases, some consumer products like cell phone time and so forth. And the goal really for both, for the model, are that companies are increasing their market share, they're generating enough profits to cover the cost of the model, and that they're also fulfilling social goals. And both companies have seen the value of thinking about not just doing donations and charitable work, but really a sustainable model that they can use and leverage their supply chains to help make happen. And ultimately, the goal is to improve the health of marginalized people in rural communities who currently lack access to needed medicines, and that the store owners and entrepreneurs that are running the stores are also running it profitably, so they're increasing their economic opportunities for their families. And then below are just, and I'll talk now specifically about the different ways that we've partnered in each country. In Guatemala, the program is called Tiendas de la Salud. It started as a pilot project with Mercy Corps' social innovations team and the in-country team in Guatemala. And again, it's a network of owner-operated health stores that are providing high-quality generics and basic health products. In the pilot, we had, as we thought about it as a foundation, we had a 3-year exit strategy. We didn't know at that time who the actual partner would be. We didn't know if it would be run as a social enterprise through Mercy Corps' social innovations portfolio. We knew that we wanted to have something that could run sustainably, which means that whatever operating entity would, the cost would be covered and it'd be, again, profitable enough to do that. And so through that pilot that we did that started in 2009, one of the suppliers of the products, we had two, Farmacias de la Comunidad, they're one of the largest pharmaceutical companies in Guatemala, became very curious around how their products were reaching into rural indigenous communities that they were unfamiliar with. And they acquired the network saw it as a way to reach, both, reaching the social goals that the program's designed to do, and also understood that they could do it if we had 100 stores at break even. And so they acquired the network. There was about 70 stores. It reached about 80 at one point. And unfortunately, to date, the Farmacias de la Comunidad is going through some pretty severe financial problems. They're both the manufacturer of all the products of the generic medicines, and they have been suffering. Their core business has been suffering. So several stores have gone out of business. There are about 40 stores to date, and we're actually seeking another partner to acquire the network. And in Mexico, the largest pharmaceutical company, Farmacias Similares in Mexico, learned about the Tiendas de la Salud program and wanted to understand if it's something that could be adapted in the Mexican context. And so we have been working linked in Mercy Corps from Guatemala over the past year and a half. I've been working with the team on the corporate side with Farmacias Similares to design, and now we're piloting an adapted model in Puebla, Mexico. I think there's a lot of promise. It's still very early stage. And I should say in both cases, the business plans were designed for both the models to understand what it would take to reach break even. In the case of Farmacias Similares, they know how to do this in spades. And we're starting with an initial corporate partner that has both a strong desire to have this reach into markets that are new to them, the indigenous communities, and also see that they want to do it on a sustainable basis and see them actually have the aspiration to do this across every state in Mexico. It's still early. It's going well. We launched the pilot at the top of last year. There are 8 stores that are operating in Puebla, and then 2 stores are targeted to open per month this year. And no more to say about that, but that just gives you a snapshot of what we're doing in Mexico. I just quickly, the key lessons learned: health reaching these last mile into this, as we say, the last mile distribution is very, very challenging to do sustainably. It's in Guatemala, we haven't reached that yet. I think there's, because of the strong partnership we have with Farmacias Similares, it's possible. We've had the time frame, the ability to reach scale and the impact that you want to achieve. It takes iteration and patience and time. And from just looking at the business model, the key to making successful both for the entrepreneur and also for the network is really having trained, educated entrepreneurs that have the health information and the business training that they need to make it a success. And that's ongoing. And that's the biggest cost for the operator to run through field technicians. And measuring the impact, we have aspirations to really understand, the levels of access that are being created through the stores. We hope in time really understanding more around, the types of health behavior change that could potentially happen with these stores. It's designed for that, but we've lost, with having corporate partners, we don't have as much control over understanding the impact. We hope to be participating with some technical expertise from our team working with Farmacias Similares in Mexico. And this, again, just a summary of the way we think about both the impact potential for both of the models on both for economic opportunity, sustainability, and improved health for the communities that they're serving in.
Nancy, I was going to walk you through the 5 questions. I see that you've actually largely answered all of the 5 questions for us. You've given a wonderful summary of the strategies used by your organization and how your investment has changed over time. I will flip through the questions rapidly. If you feel like you want to stop on any and elaborate a little bit more, this will be the time to do that. Is that okay?
Yeah, that sounds great. Thank you.
So question one was, what does success look like to you? I feel like you've given us an answer. I'll move to question 2.
Great.
Again, I think you've given us an answer. I'm going to keep moving forward unless you let me know.
Yeah, good. Yeah, I think so. Yeah, I kind of embedded these into the presentation.
Absolutely did. Yeah, I think you've addressed all of these, Nancy. With your permission, I'll move on to introducing Nathan, and then we'll get an opportunity to engage you in discussion afterwards.
Great, thanks.
Thanks, Nancy. All right, folks. Thank you again, Nancy and Juan Carlos. I'm pleased now to introduce Dr. Nathan Blanchette. He's the program director at the Results for Development Institute, where he provides leadership on R4D's health systems reform portfolio, including the design and implementation of national health insurance in South Africa and Ghana, and the USAID-funded Health Finance and Governance Project. Since 2014, Dr. Blanchette's team at R4D has been partnering with Population Services International to analyze options for the financial sustainability of PSI and its affiliate social franchise networks in a number of countries. Dr. Blanchette is going to walk us through his work, looking forward to it, and also to flag to the audience, he is joined by a few others of his colleagues who are engaged in the same project, and they may be also contributing remarks along the way. Over to you, Dr. Blanchette.
Hi, good morning. Thank you, Reka, and thank you again to the UCSF Global Health team. It's a real pleasure to be here. This is the first time that my team and I get to talk about some work that we've been doing over the past year and a half, so we're very excited, and this is just a really great opportunity for us to be able to talk with this community of practice. So I will tell you a little bit today about an approach that we've developed that we think is both analytical and participatory to work with PSI's social franchise platforms and their affiliated platforms as they work to try to enhance their financial sustainability. This is work that's done under a project called CIFPO2. I'm sure many of you are familiar with it. It's a USAID global program to support international family planning organizations. It's the second iteration of this kind of support, and in the second iteration there was a greater emphasis on the theme of financial sustainability, which has allowed us to be able to partner with PSI. So I want to give thanks to USAID and also PSI for helping set up this collaboration. Today I will walk through, I want to try to cover a few different things. First, I'll let you know a little bit about what our objectives are in this work and the framework that we use and the approach that we use in working with these social franchise platforms. We've so far worked with platforms in Tanzania, Uganda, and most recently in Nigeria. So I'll walk you through kind of what we do and why we do it, and then I'll sort of wind up with illustrating some examples of results that we've had from our most recent work in Nigeria. So this work really has two major objectives. The first is to help support PSI social franchises to become more financially sustainable. But there's a second part to that that's very important, and that's that they want to become more financially sustainable while also improving, or at least doing no harm to, the major social franchising goals of access, improved quality, improved equity, and cost effectiveness. So you'll see a lot of all five of those concepts in our work here. At the same time, we're trying to help PSI explore, I would say, and their various social franchise platforms explore potentially new roles for their clinical social franchises. at the interface between public financing and private delivery of care. I'm sure that's an interface that's very familiar with many of you, and it has risen, I would say, on the global health agenda in importance, particularly as the movement for universal health coverage matures a little bit and moves beyond some of the initial focus purely on financing mechanisms, and as it now moves toward looking at better coverage of actual high-quality service delivery and better ways to organize that, better ways to link up the public sector and the private sector, we are starting to see and believe that there may be a very important role for clinical social franchises to play at that interface. So that's kind of in the backdrop. Let me share one more hidden objective. We have a hidden objective that our reports hopefully will not just sit on the shelf somewhere, and that really influences a lot of kind of how we go about our work, and I'll get into that more when I tell you our approach. Let me pause for a second here to say something about what the other speakers have also said about, which is how we're defining financial sustainability. As you might tell from this slide, where I have more or less even embedded in the title, we have had a lot of debate about this and a lot of discussion, and we definitely do not see financial sustainability as a black and white. You're either sustainable or not. It's not a binary concept. We also don't think it's a concept that is very easily generalizable across many different contexts. Where we have ended up in our definition is that a social franchise, we would consider them to be more sustainable, more financially sustainable if they use a greater diversity of funds, typically from a mix of donor, public financing, and private financing, as they pursue their goals of quality, equity, adding additional services, cost effectiveness, and of course, ultimately the health impacts that they're looking for. As I mentioned, we expect financial sustainability will look quite different depending on the country and context. If you're in a low-income country with very low contraceptive prevalence rate and a country that gets a lot of attention from donors, then it may be perfectly sustainable to plan for quite a bit into the future to rely on donor funds. In other places, particularly middle-income countries where you're starting to see more pressure for a donor transition, obviously a higher reliance on donor funding may raise more flags about sustainability. We expect sustainable franchises will also just constantly be changing, growing, adapting, and really adapting to the health financing context and the system constraints that they find in the country. So happy to come back to that discussion of definition later. So this slide here begins to show where we start in our work with various social franchises and how we think about the framework that guides our work. You'll see this is when universal health coverage met clinical social franchises. And what you see here, I'm sure many of you will recognize this, is a mashup really of several different theories and frameworks that largely start with what comes out of the universal health coverage movement, if you will. You have the WHO's building blocks. You have the Harvard or World Bank flagship course control knobs. You have three very familiar, for health financing folks, three very familiar functions of health financing. Revenue collection, the pooling function, the purchasing function. Where all of this really meets and has a great deal in common with clinical social franchises is in the intermediate outcomes here. The whole theory behind a lot of the universal health coverage work is that these financing tools or levers really matter and really affect intermediate objectives such as access to care, such as quality of care, efficiency, equity, and that those really then lead toward the impacts that we all care about: improved health, a more responsive system, financial risk protection. That red circle symbolizes that the common ground really between UHC and clinical social franchises is in the pursuit really of the same intermediate outcomes, and then of course with the health system goals. So this is where we start. It's a theoretical framework that guides us, and it's also where we start the conversation with partners in social franchises that we start working with, and we try to both come to consensus that this is in the background, kind of guiding what we're working on. So we go through 4 major components in working with a particular platform, and those are shown here. We do some of this work prior to actually visiting the country, usually spend about 2 weeks in country working with a platform. We try to do as much as we can before we go to assess the needs of the platform. That's looking at their current situation, where does their funding come from, what kind of providers do they have, who are they serving, and what goals do they have. Many of them have worked on their own strategies and already have a direction they're trying to head in. The health markets analysis looks at all of the forces shaping the supply and demand for the family planning, reproductive health, and other primary care services that the social franchise is providing. A health financing analysis is, I think, what it sounds like it is. It's a national level landscaping of sources of health funding, mechanisms to pool funding, mechanisms that are used in the country to purchase, and essentially lays out the context of all those sources and pooling and purchasing mechanisms that a particular platform finds itself in. Finally, those 3 more analytical kind of preparation pieces all lead into a very collaborative ideation work that we do in person with a platform. And I'll go through that a little bit more in the next slide here. So once we're working in person, this is really, we really are trying not to play just an external advisor or expert role. It's really much more of a facilitator role that we play to bring out the knowledge that exists, the deep knowledge that exists in these platforms, based on the skills they know they have and the country environment that they find them in. We do a little bit of awareness raising and training on some health financing theory and concepts that are not always familiar to all of a social franchise platform staff. We then work together to build the evidence, to do more interviews in country, validate the desk research, and then we really come together and we are triangulating together between health financing options, what the platform needs and where it wants to go, and some of the major tools that might be considered if a platform wants to, for example, start to try to leverage public financing. Finally, we come up with usually a series of options, and then we evaluate those against the platform's own goals for itself and the social franchising goals, and I'll show you an example of that coming up. So these are just some of the typical tools that guide some of the options that get developed. I'm sure you have all seen these before. These are ways in which a social franchise platform might consider engaging, particularly with the public sector on the first 2 options, contracting with the government or playing some kind of facilitator role, or with public insurance programs, whether that's a national health insurance program, a community-based health insurance program, or even private for-profit insurance that exists in some countries. And then just looking within the network and focusing more on the private side of financing, there are options that usually get categorized under cost recovery options. So those are some of the major tools in the toolbox, with varying details under each of them. So that kind of lays out the approach and some of the steps that we take with a platform. Sorry to go through this pretty quickly. Let me now transition to an example from our recent work with the Society for Family Health organization in Nigeria, and particularly their Healthy Family Network. So the Healthy Family Network, some of you may know, is a large network social franchise platform in Nigeria. They have 656 franchisees in 23 states. They have, and if you look at the left side of this slide, you'll see a upside-down pyramid shape, which represents their current structure of providers. They actually have the highest number, about 50% of their franchisees are hospitals and maternities, then pharmacies, then private medicine vendors. Those are very low-level, almost informal sector medicine vendors. And then you have at the bottom of the Nigerian system, but not yet in the Healthy Family Network, primary health care clinics. The Healthy Family Network is a very successful network. I won't go into a lot of detail, but it's very well known in Nigeria, provides a lot of great services, very well known to be a key implementer for major donors in Nigeria. And it wants to try to transition and strengthen its Healthy Family Network franchise. And the problem, one of the problems they're facing, is that they do not have a dedicated source of revenue for the franchise itself. And they are trying over time to be able to use that franchise as the major platform, the major delivery channel for all the services that they provide. And they're doing this, of course, in the context of universal health coverage, ongoing health financing reforms in Nigeria, and their own recognition that they really want to do a better job of reaching quintile 1 and quintile 2 populations in Nigeria. So what you see here on this slide is, as they look toward the future, a possible direction for them in expanding the scope of services for their franchise, particularly at the bottom level, so that you end up in the future with a greater proportion at the lower levels that tend to serve more of the Q1 and Q2 populations. And what we did was we recognized they have different needs at these different tiers of providers, and we developed some financing options with them that cater to those different tiers, and that's what you see referred to on the very right as options 1 through 5. So I will go through some of these quite quickly, and we can come back and talk in detail if anyone would like. But this slide shows the 5 options that were drafted very recently in Nigeria. You have option number 1. This is really within the cost recovery category. This is a package of services that they could provide to some of their higher-end hospital facilities on a cost recoverable basis. And then steps 2 through 5 are really a mix of contracting and insurance options. You have things that are simpler, such as step number 2, which we've called baby steps, where they may develop a relationship with the public sector simply to help channel public commodities through a larger network of providers by using their HFN maternities. That might be a baby step in the sense that it could show value of the franchise to the public sector and hopefully set up more public-private collaboration in the future. Some of the other options involve helping with some of the emerging insurance schemes and getting their franchisees enrolled in some of those schemes. And lastly, option 5 is this a novel approach to potentially franchising in, you might call it, some of their franchise services into public primary health clinics, especially in rural and underserved areas. Nigeria actually has a national strategic goal to ramp up 10,000 new primary health care centers, and this may be one area where they need the greatest amount of assistance from private from the private sector. This next slide just shows that last option of franchising primary healthcare centers mapped out a little bit, and you'll see one of the things that we do here in the impact analysis with the platform partners is to specify what the impact would be, what the perspective would be from the various stakeholders involved, the clients, the franchise itself, the Healthy Family Network, the franchisees. There often is this difference between the franchisor and the franchisee perspectives and other stakeholders. And that flip chart picture that you saw was our manual version of what you now see this chart. So this is not highly scientific, but a group expert opinion informed assessment of the various options that we came up with and how they impact the various social franchising goals, which is meant to be used as a guide for when the platform decides which of these do they really want to do a deep dive into. So a few key takeaways, and then I'll wrap up. Even social franchises that have not thought a lot about universal health coverage or public financing, even ones that have been on the march toward and under strategies that heavily emphasize cost recovery, I would say even among those we have found a genuine openness to working more and connecting with public financing sources, particularly as people think more about sustainability and equity. We do find a lot of evidence that social franchise platforms could become effective intermediary organizations. This is something some other colleagues of mine at R4D have been doing a lot of thinking about, and the social franchise platforms definitely fit a lot of the characteristics of effective intermediary organizations to help that channeling between public financing and private providers. Then another thing is clearly this is just kind of the first step, and it's a long road ahead to go down any one of these options. So the various platforms that we've worked with are now thinking about what it really takes to move some of these forward. Just finally on a note about our approach, I think it's very important, particularly when you get one community of practice, if we can use that term even here, with another. Let's say people normally working on universal health coverage, perhaps taking a more governmental perspective sometimes, and a social franchise community that has been immersed in the private sector and perhaps in some places has not had much engagement with the public sector. You really need to think carefully about an awareness-raising strategy, a change management strategy. And so far we've had pretty good luck with working in this participatory way with various platforms. So we're hoping we can continue that and would certainly recommend it to others. Okay, let me stop there. Just to thank my team, Adil Lishtiak and Aparna Kamath, my colleagues at R4D. And I have to give special kudos to Cynthia Eldridge. I'm sure many of you know her. She's taught me everything I know about social franchising, which is only a small fraction of what she knows. And Pierre Moon is the director of the CIFPO 2 project. If you have particular questions about that, he is at PSI. Thank you, and back to you, Rika.
Great, Nathan. Thank you so much. I think each of the presenters has given us a really sort of a lovely and succinct, distinct visions here. We've heard from Nathan and from Juan Carlos, we heard a historic perspective on how franchises envisioned sustainability, financial sustainability in Bangladesh. From Nancy, we heard a very succinct vision for how corporate partnerships were really an integral part to the formulation and the execution of their financial sustainability strategy. And from Nathan, we are hearing prospective, what are the greatest prospects for financial sustainability in certain countries in Africa through PSI, and it sounds like he's suggesting diversified funding sources, diversified functions, and envisioning really a new role for the franchisor within an integrated systems approach. Let's open this up to discussion. We've already had a number of folks post their questions. So I'm just these one by one, but I will still encourage you to keep chiming in, keep putting in your questions, and we'll try to get through all of them. A lot of you have asked, will these slides be made available to you? We will not send you the slides. We will, however, send you a video recording of this entire webinar session, and you'll probably receive that message in the next day or two. Is that right? Okay, great. Okay, so let's go through the questions. We've got a question from Joyce. Joyce asked a question to Juan Carlos, and she wanted to know how did the Smiling Sun franchise increase services to the poor? And she asks, was insurance used as a primary strategy?
Well, first of all, insurance was not used as a primary strategy, and perhaps going back to the one of the last slides from Nathan. Well, the idea was to place Smiling Sun as a player that could negotiate with private institutions that were willing to provide access to healthcare and services to their employees. One, and also to work with the government in different capacities. One of them was to get Smiling Sun involved in a voucher program. So it is a quasi-insurance, but it's a scheme, but does not fulfill all the requirements of it. So that was an element of Joyce's question. What was the other element? Sorry, Reka?
I believe that. How did you increase services to the poor?
Well, very simple in terms of the strategy. We did, I think, was a combination, the right combination of pricing and promotion, and also reaching through channels that would lead us to them, like working with government sector companies.
Thank you, Juan Carlos. We have another question from Joyce as well to you. She would like to know how Smiling Sun achieved cost recovery. And is cost recovery, was it thought of as cost recovery for the franchisor?
Well, in cost recoveries, we had a network of franchisors. I mean, we had 27 franchisees, every one of them with an average of 30 clinics. Sorry, 20 clinics each. And so that was the structure that pretty much we had. So sustainability was reached at the clinic level, and that was relevant for the franchisee. And so the aggregate of financial of revenues at the clinic level determined the revenues of the entire franchisee. The franchisor was at the same time working in a different space through getting a cut, for instance, from selling drugs to the network, and getting a cut through the negotiations that they were doing with garment industries, and also participating as distributors of different drugs and contraceptives. Through this mechanism, the franchisor was deriving revenue, but the sustainability, the cost recovery index that you saw was for the entire network.
Great, thank you, Juan Carlos. And another question for you is, Juan Carlos, after you left the project, you mentioned USAID moved away from the social franchise model. How did they change the model, and why do you think this was?
Well, I think USAID, frankly, was never too comfortable with the tension that was and that created having a financial objectives that sometimes it seems to as you saw in the second year of the project, it hurt a bit in the reach of the project to the poor, even though it was recovered later. And at the same time, I think that when in the design phase of the project, there was not such a great buy-in of all stakeholders, both in the mission and outside, to develop the project. So regression was a possibility and needed to happen.
Okay, thank you for that context, Juan Carlos. Let's move to a question for Nancy, I believe. Julie, correct me if I'm wrong. This is a question from you. How can processes that lead to results in financial... Oh, I'm sorry. This is a question for Juan Carlos again. How can processes that lead to results in financial sustainability positively impact quality and access?
Well, Perhaps when looking at the factors that help us to address the determinant elements in sustainability, one of the elements that we identified was this differentiation through the way services looked and were felt. So that was a quality element. So I would put it pretty much in the other way around. So working on quality for us, I know that there are a lot of studies that question this, but also others that confirm it. Working on the definition of quality according to clients and also according to providers for us was critical in creating a sense of value and for people to demand our services.
Thank you. Nathan, do you want to take a crack at that as well? I think that was actually a question for maybe you and Juan Carlos as well.
I'm sorry, can you repeat that one?
How can processes that lead to results in financial sustainability positively impact quality and access?
Yes, okay. So, yeah, I think that one of my slides might show that here. We take that question up very explicitly when we look at any particular financing option. Let's say we say, all right, a country has a national health insurance scheme, but the franchisees in the network are not participating in this. We want to help them get impaneled with the health insurance scheme and help them do patient education in their communities to get insured folks in their doors. That obviously helps franchisee with financial sustainability because they get more patients who are covered by a third payer. It may help the franchisor if they can convince the franchisee that that's something worth paying a small fee for, or maybe then taking a small percentage of an insurance payment, et cetera. But then what does it do for access and quality? Typically that kind of option could have a positive impact on access, because if you go from a situation where you're just relying on out-of-pocket payments, you typically expect that is limiting access, particularly among the poor. If you get an insurance program that actually works and targets the poor quite well and gets them through the doors, that can improve access. Quality could be have to depend on an insurance program, but it could, in that case, be a part of the accreditation process that a particular provider would need to go through to be impaneled. And there may be other ways to improve quality through the monitoring of provider prescribing patterns, for example, under the new insurance scheme. So basically, that's one example, but basically the point is that for each one of these, you can expect to have some kind of impact, and sometimes it's a neutral impact, but other times it's a lower or higher impact on some of those social franchising goals, depending on how the financing mechanism works. That helpful?
That was great. I will move to the next question, and there's definitely more questions aimed at you, Nathan, in the future. This next question is for Nancy. Nancy, what in the TISA model required adaptation in Mexico? What remained the same? What needed to change?
For the most part, the model remained the same. I think what was adapted, the biggest piece of it for Mexico was really understanding the communities in which these stores are going to exist. And so it really required more than just having a manual and a way to understand how each of the components worked. It required having Mercy Corps really help them understand the Farmacias Similares team, how to go into the communities, recognize in the local leadership, work with the local leadership, and get a sense for the culture and the sensitivities and the language and all the things that were new to Farmacia Similares working in these indigenous communities. So, they really had to look at the process and how they were going to do that that met the needs in Mexico. I mean, that's the first thing that comes to mind, and that's still the biggest challenge right now is working in the right communities where there's the ability to pay, and then having the staff understand, how do you really work in these communities, identifying the right communities where these can work, and also then how do you understand the profile of the entrepreneur that is necessary to run the stores. So that's what the kind of the biggest effort in terms of the adaptation at the stage that we're in the pilot.
Great. Thank you, Nancy. Nancy, a question for me to follow on from that. Do you find that your general framework for operation in Guatemala can apply in Mexico, and it's mostly sort of how it's applied in Guatemala is quite different, but the framework is common?
Yeah, I think that the overarching framework is adaptable. What we're seeing in Mexico, because of the strength of this company in Mexico, Farmacia Similares, they know how to. I mean, they've got over 5,000 franchises in every state in Mexico. I mean, they're so business savvy, and they know how. They've got the internal systems and mechanisms and the marketing and the branding down so well. It's still in manual form, but the idea is that they'll be able to use some technology to make it more efficient in the rural communities. But they really know how to leverage the aspects of the business and have such a large footprint. So we're really seeing the effectiveness of that as they train up and teach the entrepreneurs and have those tools already because of how they do business, their core business. So I think that's a big advantage, and then they're adapting that into kind of the local context that they're working in.
Thank you, Nancy. I've got another question for you. How does your foundation assess the scalability of potential projects?
That's a great question. We revisit it often. At a minimum, we think about, that really would be that the model can be adapted in other countries, like what's happening in Mexico from Guatemala. That was always the idea, that we have something that could be replicated in other countries, and hopefully, outside of Latin America as well. But I think Mexico is really, we really want to prove that this is, that really proves the concept. When we think about it in country, we've had kind of at a minimum threshold that the business can reach over 100,000 people at kind of an that's always the aspiration in both countries is a lot higher, and that hasn't been reached in Guatemala. So we think about both adaptation, replicability, and then thinking when we're screening through potential investments, 100,000 roughly as a place to start.
Great, thank you, Nancy. Another one for you. What initial investment is required for new franchisees? Do you help them secure capital they need to start up? Mm-hmm. And how long does it generally take for them to recover their investment?
Mm-hmm. So what with both in both Mexico and Guatemala, part of what Link helped do in Mexico and then in Guatemala was the program requires a financing partner. So in the case of Guatemala, Farmacias de la Comunidad, because of their the relationships they have in the business community, was able to work with the largest bank that's serving the poor Ban Rural. When they acquired the network prior to that, the funding for the pilot, we included the financing for the entrepreneurs in, and then, as I mentioned, Ban Rural stepped in to be the financing partner, and they provided very good terms. It's roughly a $800 startup loan over an 18-month time period at 12%. And going forward in Guatemala, I don't know if Banral will play a role, or even if that, there's going to be opportunity to scale the TISA stores. And then in Mexico, we help identify a financing partner, a microfinance organization that's working in Puebla, and they are offering similar terms at a similar loan amount. And again, it's still early there to say, but so that now that we know, the financing partner is just a key partner in making the model happen. So it's finding that partner at the outset, which in the case of Mexico, they're able to identify potential clients as entrepreneurs for the stores, and so there'll be lots to learn in Mexico going forward.
Great. My next question is to both Juan Carlos and to Nancy. What is the contribution of the franchise? How much are the franchise fees, first of all? And what's the contribution of the franchise fees towards the overall sort of income stream at the network level?
Nancy, you want to go ahead, or?
Initially in the pilot there was a franchise fee, and I can't remember the amount or the percentage, the overall contribution. I'd have to look back and see. And there's not a franchise fee currently in the Mexico model.
Well, as part of the Smiling Sun social franchise design, there was a fee, and the fee was supposed to increase gradually across the life of the project. It was never implemented, and several reasons. One was in the initial relatively low levels of cost recovery at the clinic level. When it was growing up, we focused our attention, and when the performance in the clinics was improving, we focused our attention on bringing more clients into the clinics. We thought it would be more important to develop what we call at that time corporate accounts, and also in working closer with the government in that regard. So I think, and also in working with the local pharmaceutical companies and to generate more revenue for the franchisor this way. Now, I think that when you look in retrospect, not implementing the fee was a mistake, or better said, a project shortcoming, in the sense that it could have also demonstrated a willingness to participate by the franchise, and that is something that we didn't see that way at that time. But the answer is no, and this is the reasons why.
Great, thank you, Juan Carlos. We have another question related to what people are willing to pay for, and this is a question to Nathan and team at R4D. Would franchisees be willing to pay for some of the services that you mentioned the interface agencies should be playing in the future? For instance, health insurance accreditation or any of the range of functions you mentioned?
Yeah, thank you. That's a great question, and it's a very important question. We did not do, as part of this work, any, let's say, a survey or anything that would gather really, solid evidence on willingness to pay by franchisees. But we did talk a lot about that issue, and we reflected on it with the staff from the social franchise platform, because they obviously need to think about whether they could put together a particular package that would be worth that franchisees would be willing to pay for. You can imagine quite different examples of this. In Nigeria, you have some very high-end hospitals who would make the decision, I guess, like you would expect any rational business to make. If the platform can provide a suite of consulting services, just like a business consulting firm might, that really that they see value in, I think that might be one possibility. A very different context would be lower-level providers who see the process of impaneling themselves into an insurance agency as very complex, hard to understand, very time-consuming. We did hear at least anecdotal evidence of that in a few different countries that seem to set up the possibility that if the franchise could make that a lot easier and kind of do that for them, play a facilitator role there, that some form of payment would be possible. And particularly if the the payers, the insurance, if you have an insurance scheme, payers often struggle a great deal if they need to set up separate relationships, contracts with hundreds or thousands of different providers. There may be a decent case to be made that franchisor could play an intermediary role of bundling payments, perhaps helping manage the delivery of capitation payments, and then take a small percentage of those for that service. So anyway, bottom line, very important question. We think that the case is there in multiple examples, but it's still a case that needs to be proved.
Thank you, Nathan. Another question for you. Do we have any examples yet of social franchises that have started with donor financing initially, but eventually moved on to significant public financing?
Yeah, great question. I would like to turn that back to the whole community here, because you all know a lot more about the global experience with social franchises than I do. All I can offer immediately is that I know that in the Philippines and I believe Malawi, there are examples at least of social franchise platforms that are currently functioning in quite a robust way, with participating in a robust way with the insurance schemes there. For example, in the Philippines, the PhilHealth does pay for services delivered by social franchise platforms there. But I would highly recommend opening that up to the group.
If either of the other speakers want to chime in, please feel free to as well. And I'm also going to give a moment just for folks to maybe write in comments, because there are a lot of experts online right now that might be able to comment. I will comment briefly on the Philippines experience. I visited there a year ago to kind of take stock of their work with the health insurance program. And it turns out, as you mentioned, that the franchisees are doing quite well. They're benefiting from participation in PhilHealth. The franchisor, however, is still strategizing on how to recover some of the costs, some of their significant costs that they incur in supporting their franchisees to become accredited. So I think it's an ongoing conversation for them as well. Okay, so we'll move. If anyone has any thoughts on that, please do type it into the comment box. In the meanwhile, I'll keep moving through the questions right now. There's a ton of questions. We've got a question to Juan Carlos. Juan Carlos, in terms of patient volumes, how have patient volumes changed over time?
Oh, shucks, I forgot my graphs on services. But we were, first of all, both volume of patients and services grew significantly. And we went from roughly 20-some million services to 40 million services in a year. This one, and also the client base expanded. But frankly, I don't have those figures fresh in my head, but I remember both expanded significantly. Sorry about that.
Okay, great. Thanks, Juan Carlos. I mean, if there's any additional slides that you want to insert afterwards, we'll do that, and then we'll make that slide set available to people if you'd like.
Okay, so perhaps something I can look at now.
Sure. Juan Carlos, did clinics become more profitable after being converted to Smiling Sun franchises?
Sorry, repeat it, say it again.
Did clinics become more profitable after they joined the Smiling Sun network? Yeah,
when going back to these bars of that financial sustainability here, this is aggregate. In aggregate, clinics increase their financial sustainability. They went from somewhere that was, our baseline was 25% for this project, but clinics were around 20% financially sustainable, and they were recovering costs at that level. Invariably, all of them went up. Some clinics, and perhaps this is important and to mention, is some clinics with richer service mix, those that we call emergency obstetric care units, in which safe deliveries were offered and a wider set of services, increased their financial and their cost recovery much more than those that didn't. But in general, all of them. The other element we saw is that clinics in the urban areas, as suspected, increased financial cost recovery more than clinics in rural areas. But clinics in rural areas also improved their financial situation.
Great, thank you, Juan Carlos. We've got a couple of folks that chimed in regarding that last question. Have any franchisors yet moved on from primarily donor financing to public financing? We've got someone that mentions the Marigold social franchise in Uttar Pradesh, which I believe a year ago, 2 years ago, Manon chime in and correct me if I'm wrong, received a contract for piloting the franchise network in partnership, contract-based partnership with the state. We also have an example from Rwanda, which is the One Family Health Enterprise in Rwanda, which they're operating nurse health outposts on behalf of the public. So we've got a couple of examples to turn to. Let's move to our next question. Oh, it looks like we're nearing time right now, and I still have 15 more questions. Let's see. My gosh, this conversation could really go on for quite a while. Really great questions here. I am really quite sorry to everyone. I will not be able to take these questions right now. I am copying and pasting all your questions. I will send them to the presenters. In the event they have the time to answer them, I will respond back to you. So my apologies again. Let me just thank the presenters again for really excellent presentations, very thoughtful work. And thank you for being so open about both the successes and the shortcomings of some of the project work that you have undertaken. We are all learning from your experiences. I'm just trying to locate some additional slides for our viewers. I want to point you in the direction of some useful resources. The Social Franchising Metrics Working Group, I believe it's a group that's known to many of you. This group represents international experts from many, many different countries, representing some of the major NGOs and smaller franchises as well. Advocates and promotes the use of metrics, standardized metrics, to measure performance in key areas. I'm pointing this out because I understand that financial sustainability is one of several different parameters for success or growth that you all are measuring. So as you take stock of performance and financial sustainability, there's also other ways to balance out the measurements. And please do refer to this website. There are tools that will help you to measure performance in equity, health impact, and other areas, and also informational content that would explain these measurement approaches. Also, there are some great resources on that SF for Health website. There is a case study of the Smiling Sun social franchise that Juan Carlos talked about. There is a qualitative evaluation of TISA done by former Global Health Group manager. And there is a really quite thoughtful and elegant framework on financial sustainability that was developed again by folks at the Global Health Group, but this was done really in partnership with a number of social franchises. And lastly, the Clinical Social Franchising Compendium, which will give you a succinct snapshot of what social franchises look like around the world. Last but not least, please do visit the websites of each of the speakers that were featured. I suspect there is really rich content on each of these websites that would be worth visiting. And again, thank you to all of you. Thank you so much, Nancy, to Juan Carlos, to Nathan, Adil, Aparna, Cynthia, everybody that participated, and Avery for supporting the planning of this process. Maybe I'll just close off there. We will follow with an email message to all of the participants and presenters in a couple of days, which will include a link to the video recording. If there's any last-minute comments from any of the presenters, please do take this moment right now to
Reka, thank you very much. Thanks to everyone for the great questions. I know there were some questions that were unanswered. You can find my email either through Reka or our website if you'd like to reach out to me. I'd be happy to interact with anyone individually. Thank you.
Well, thank you, Enrica, for organizing all this and your team, Ari and all. And thank you for the participants as well. And same here. If you have questions, I'd be more than happy to entertain them through you.
Yeah, and I just echo the thanks, and I would be happy to answer any questions as well. It's a great opportunity for learning. Thank you.
Wonderful. I'll just ask the presenters to, if you don't mind, to stay on for 2 more minutes, but we'll close off the line to everybody else. Thank you all.